I hope that's what your topic is, right?
I don't know. It's just a repetition of the previous topic. So, or most of the slides are also same. So I'll just give a glimpse regarding this first line therapy. So the map. The progression-free survival in the first line is something around 6 months, with the OS is of around 36 months. So that definitely it is less as compared to Nivo-EP in this group of patients. So what we say with this trial, that Nivo-EP is still the standard of care. But if you are starting with Nivo, in that case, adding a boost surely improves the response rate in this group of patients. And this study has got its major role in the second line Nivo. If the patient is using on the second line, in that case, Nivo plus EP might be considered as a rescue strategy. Regarding this Pembro plus XZ data, already we have discussed. So it has got a definite benefit and the response. So surely if the patient is having a bulky disease, you may go with this and you want an early response. So a TKI has to be added in this group of patients, especially in intermediate poor risk. Regarding the favorable risk, though the OS benefit is not there in this group of patients, but still you can use Pembro-Exiv in the patient with a favorable risk because the response rate is higher with this drug and the PFS benefit is there with this drug. So I'll discuss that later. Regarding Nivo cabozantinib, so when to use this drug? So basically it is said that Nivo plus cabozantinib has got a major role in the bone disease and if there is a CNS involvement. So in these two subgroup of patients, you may consider this more as compared to other drugs. So, and otherwise it is being used mostly, as we say, in the intermediate and poor risk has got a higher benefit in this group of patient. Further, not in the favorable. In the CLEAR study, that is the Lenva and pembrolizumab. So now the data updated analysis for this has also come, and this has been presented in this ESMO only. And in this updated analysis, they also showed that the PFS and OS, which is being lacking for the Pembro plus Len, and now it has come and it is still showing a greater benefit with Pembro plus Len in this group of patients with a complete response rate going in the order of 17%. So earlier it was something around 16%, and after this updated analysis, they have shown that the complete response is 17% in this group of patients. And if the patient continues for Pembro for something around 2 years, so it is seen that around maximum intermediate and poor risk patient has continued this Pembro for around 2 years. So they have got the overall survival at 36 months, 3 years, 95% in this group of patients. So if the patient is going good on Pembro and Len, so they have got a good survival in these patients with the updated analysis. Avelumab exitinib, the data has earlier out for PFS, and it is showing that it's also a PFS benefit, but OS is still in that case. The other study is the COSMIC, which has not been discussed in the previous. So this has taken Nivo-EP in combination with cabozantinib in this group of patients. So this a triple drug, and the toxicity surely one have to think before giving this. So it has shown that the PFS with cabozantinib Nivo-EP is is higher as compared to placebo with Nivo-EP. It is something around 10%, 12% extra benefit. And the response rate, what we say that with Nivo-EP, around 75 to 80% patient response, but with this regime, it is 90% of the patient is showing a response. So surely cabozantinib with Nivo-EP is a good option, but if you can manage the toxicity, and somehow it has shown that it is worked better in the intermediate group rather than in the poor group. So it has got a benefit somehow in showing much better in the intermediate group. Adverse event surely is higher as transaminitis, diarrhea, and skin reactions are more in the case of cabozantinib group as compared to the Nivo-EP single agent group. So if we say for the intermediate and poor risk disease, surely Nivo-EP and Pembro-Exiv, you have to choose and discuss with the patient, and on the tempo of the disease, you have to decide whether you want a early response or you want a delayed response. And regarding the age of the patient, whether endocrine manifestations and whether you want to manage or not. For favorable risk, Pembro-Exiv has a choice because the overall response rate is something around 70% with this Pembro-Exiv combination as compared with 50% with others. And the CR rate is too high with this 11% as compared to with sunitinib 6%. So even with no OS benefit, this regime is being preferred in the favorable risk group. Cross-trial comparison already with Pembro-Len having the best response of around 71% in all group of patients. And so we will say with all combination, it's the Pembro plus Len has got a easier toxicity profile also and have the best PFS of around 24 months as compared to all others. Regarding non-clear cell RCC, we have got some phase 2 trial of Lenva plus pembrolizumab, and they have also showed an overall response rate of something around 48% in this group of patients. So there is a data. So for first-line combination therapy, risk stratification is the must thing, and with favorable risk, you may go with immune checkpoint inhibitor with VGFR. Wait and watch policy is also important in certain group of patients, and single agent VGFR TKI can also be considered. For intermediate poor risk, it's both the immune checkpoint IO or IO plus TKI consultation has to be done with this group of patients. With this, I'll end. Thanks.